Hi everyone, I am Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that to help you to recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of the pleura as well as the bronchopulmonary segments into clear, high-yielding, exam-focused concepts. So let's get started. The pleura, just like the peritoneum, it is a serous membrane. It's a serous membrane which lines the inner surface of the thoracic cavity as well as the lungs. So this serous membrane is lined by flattened epithelium, which we call it as the mesothelium. And this mesothelium here secretes a watery lubricant, which we call it as the serous fluid. So when we see, so the pleura will have two layers, the parietal and the visceral, okay. And between the two layers, there will be a cavity which we call it as the pleural cavity, which is enclosed between the two layers. So the visceral pleura will be adherent to the lungs, whereas the parietal pleura will be attached to it will be lining the inner surface of the thoracic cavity, that is the ribs. So the pleura consists of two layers, one is the visceral layer, another one is the parietal layer. So this visceral layer is firmly adherent to the surface. All the surfaces of the lungs are covered by this visceral pleura except at the hilum, okay, except at the hilum and along the extension of the pulmonary ligament, okay. Along the extent of pulmonary ligament or along the attachment of the pulmonary ligament, we do not see the visceral pleura. And rest of the area of the lung is covered by the visceral pleura, which also extends along the fissures of the lung. Then we have the parietal pleura. So this is the parietal pleura, and parietal pleura is thicker, okay, it is thicker than the visceral pleura and it lines the walls of the pulmonary cavity. So this parietal pleura is like of a cone, okay, so it will be lining the thoracic wall, okay, the diaphragm as well as the lateral surface of the mediastinum, and it also as well as the Simpson's fascia, that is in the cervical diaphragm. That's okay, Simpson's fascia is called the cervical diaphragm, so it lines that part also. So the parietal pleura is lining the thoracic wall, inner surface of the thoracic wall, the diaphragm, the lateral side of the mediastinum as well as the Simpson's fascia, otherwise called as the cervical diaphragm. So now, for description purpose, we divide this pulmonary pleura into four, okay, so four parts. So we have along the ribs, the part which is covering the inner surface of the ribs, we call it as the costal pleura. Then we have the diaphragmatic pleura, which covers the diaphragm, superior surface of diaphragm. Then we have the mediastinal pleura, okay, the mediastinal pleura, which will be lining the corresponding surface of the mediastinum. And we have the cervical pleura. Cervical pleura. So the costal pleura, it lines the inner surface of the thoracic wall and it is attached to this thoracic wall by the loose areolar tissue, which we call as the endothoracic fascia. Okay, so this the costal pleura is loosely attached to the thoracic wall by what we call as the endothoracic fascia. So this endothoracic fascia is loose areolar tissue basically. And then we have the diaphragmatic pleura. So diaphragmatic pleura covers the superior surface of the diaphragm here, and the mediastinal pleura covering the corresponding mediastinal surface of the corresponding mediastinal surface, okay, so and it forms the lateral boundary there. And then we have the cervical pleura. So the cervical pleura, when we see, it is the dome of the ear, the dome shape, this portion, we call it as the cervical pleura, and this extends into the root of the neck at about 2.5 centimeters above the medial end of the clavicle, and about 5 centimeters above the first costal cartilage. Okay, so about 2.5 centimeters above the medial end of clavicle, and at the above the first costal cartilage it is about 5 centimeters above. So up to that it extends, and this part we call it as the cupola. Okay, so this portion we call it as cupola and covers the apex of the lung. So this cervical pleura here is called the cupola, okay, and it covers the apex of the lung. So we need to be very careful while penetrating this area with an anesthetic needle, because we can injure the lung. Okay, so care must be taken. And here it is covered by the suprapleural membrane, which we call as the Simpson's fascia. So coming to the relations of the cervical pleura, anteriorly we have the subclavian artery. Okay, so anteriorly there is the subclavian artery and the scalenus anterior muscle. Scalenus anterior muscle. So posteriorly, okay, behind here, posteriorly at this part, there is the neck of the first strip. Okay, neck of first strip along with the structures in front of it. So what structures are there posteriorly in front of the neck of the first strip? Neck of first strip. Okay, so what are the structures we see there? We see the sympathetic chain. Sympathetic chain. Then we see the first posterior intercostal nerve, intercostal vein. Then we have the superior intercostal artery, superior intercostal artery, and the ventral ramus of T1, spinal nerve. Okay, so these three structures will be in relation to the neck of the first strip, and they form the posterior relations of the cervical pleura. Then on laterally, okay, so on the lateral side here we will have the scalenus medius muscle. So laterally there will be scalenus medius muscle, and medially here if you see there will be the great vessels, all the bigger vessels, medially great vessels. Okay, great vessels of the neck, which include the internal jugular vein we have, then the common carotid. Okay, so those are present here on the medial side. So this is about the relations of cervical pleura. Then coming to the pulmonary ligament. So the pleura here surrounds the root of the lung. Okay, so just like how we see a sleeve of the jacket, okay, around the wrist. So wrist, and that will be hanging down, right? Just like here. In the same way, the pleura will surround the root of the lung, and it will extend downwards as a fold, and this fold we call it as the pulmonary ligament. So this will be extending, okay, so it from the root of the lung up to the diaphragm, okay, up to the diaphragm, this pulmonary ligament will be extending. And this fold is filled with, the pulmonary ligament basically contains loose areolar tissue, as well as lymphatics. Okay, it will have some lymphatics and loose areolar tissue is present. So that is in the pulmonary ligament. Now what is the function of this pulmonary ligament? So one thing is it provides a dead space. Dead space for what? Dead space so that the pulmonary veins can expand into that space during increased venous return. Okay, during increased venous return, the pulmonary veins will expand, and this dead space will provide the space for its expansion. Then the second thing is it also allows the descent of the root of the lung. Okay, allows the descent of root of the lung when along with the diaphragm, okay, during the inspiration. So, during inspiration, it will allow the descent of the root along with the diaphragm. So, this is another thing. So, because of that, what happens, since it is descending down like that, the apex, okay, so the apex of the lung will come down from that suprapleural membrane, leaving an empty space below the membrane in the apical part, okay. So, that is about this pulmonary ligament. Next important thing which you have to know in regards to the pleura is the recesses of the pleura. So, normally the space between the parietal pleura and the visceral pleura, it's just a small potential space which is filled with fluid, with the thin film of fluid, serous fluid. So, that is about 5 to 10 ml, okay. So, 5 to 10 ml minimal fluid is there to basically to prevent friction and for easy lubrication. But okay, in certain areas of pleural reflection, that is where it reflects onto the diaphragm and then to the mediastinum, the space between the visceral pleura and the parietal pleura is expanded there. So, slightly expanded, okay. So, generally all around the thoracic cavity and the lungs, the parietal and the visceral pleura, there is a very small potential space filled with the serous fluid. But where the parietal pleura will reflect onto the diaphragm as well as the mediastinum, there the distance between the visceral as well as the parietal pleura is increased, okay, and that spaces we call it as the recesses. So, why do we have this? They are basically helpful for the expansion of the lung during deep inspiration. So, when we inspire deeply, the lung, when it expands into these spaces. So, recesses, they basically serve as a reserve spaces, okay. They form a reserve space for the expansion of the lung during inspiration. So, there are mainly two, spaces, mainly two, which we call it as the costodiaphragmatic space, and then we have the costomediastinal space. Okay, so costodiaphragmatic recess and costomediastinal recess. So, these spaces are paired spaces. We see both on the right side as well as the left side. So, in addition to that, there are three more small recesses. Okay, so 3 small recesses are there, which are the right and left retroesophageal. Okay, so right and left retroesophageal, that is behind the esophagus, which is formed by the reflection of the mediastinal pleura behind the esophagus. Okay, so 3 small recesses. One is the right and left retroesophageal recess. Another one is the infracardiac recess. Second is the, so 2 here, right and left paired retroesophageal recess and infracardiac. Okay, so it is a small recess of the we see it on the right side, of right pleural side, which will extend a little beneath the inferior vena cava. So that is the infracardiac. So these are the recesses of the pleura. Okay, so mainly the costodiaphragmatic and costomediastinal recesses are important here. So when we see the costodiaphragmatic, okay, so the costodiaphragmatic recess here is located inferiorly between the costal and the diaphragmatic pleura. Okay, so in this space we have the costodiaphragmatic recess. So it is about 5 centimeters vertically in length. Okay, vertically it will be about 5 centimeters, and it will lie against the 8th to 10th ribs. 8th to 10th rib in the mid-axillary line, okay, mid-axillary line. So these recesses are the most dependent part, okay, dependent parts of the pleural cavity. So whenever there is pleural effusion, that is collection of fluid, excess of serous fluid in the pleural cavity, we call it as pleural effusion, and this we first see in the costodiaphragmatic recess because it is the most dependent part. Then we have the costomediastinal recess, so that we see here. Okay, that is anteriorly between the costal and the mediastinal pleura, and lies between the sternum and the costal cartilages. In this part, we see the costomediastinal recess. So, here when we see the right costomediastinal recess, okay, so the right costomediastinal, what happens is, it is occupied by the anterior margin of the right lung, okay, even during quiet breathing, okay, even during the quiet breathing, it is occupied by the right anterior border of the anterior margin of the right lung. Costomediastinal recess is formed by the reflection of the costal and mediastinal pleura, okay, so costal and mediastinal pleura, and it lies between the sternum and the costal cartilages. So, here now on the right side, right costomediastinal recess is smaller, because even during quiet respiration, the anterior margin of the right lung occupies that recess. But whereas on the left side, okay, the left costomediastinal recess is large. Now, why is this large? Because there is the cardiac notch. Because of the presence of the cardiac notch, the left costomediastinal recess will be large. Okay, so when we can identify that recess by tapping. When we do the tapping, the lung gives a resonant note, and while we come towards the costomediastinal recess, it gives a dull note. Okay, so the note changes in a normal individual. It note changes from resonant to dull when we percuss on the recess region. Okay, so this area we call it as the area of superficial cardiac dullness. Then when we talk about the nerve supply of the parietal and the visceral pleura, it goes with the development. So, parietal pleura is formed by somatopleuric layer, okay, of the lateral plate mesoderm. It is formed by the somatopleuric layer of the lateral plate mesoderm. So, it is supplied by the somatic nerves, because of which it is sensitive to pain. We can feel the pain. So, the costal pleura, the parietal pleura, as well as the peripheral part of the diaphragmatic pleura, they are supplied by the intercostal nerves, whereas the rest of the diaphragmatic pleura and the mediastinal pleura, they will be supplied by the phrenic nerve. Okay, the central part of the diaphragmatic pleura, parietal pleura, and the mediastinal pleura is supplied by the phrenic nerve. Whereas the visceral pleura, it is developed from the splanchnopleural layer, okay, splanchnopleural layer of the lateral plate mesoderm. So, that is supplied by the autonomic nerves, that is the sympathetic nerves from T2 to T5. So, it is insensitive to pain. So, coming to the applied aspects, so one is pleural effusion. So, what is pleural effusion now? Pleural effusion is the collection of excess of fluid in the pleural cavity. So, normally I told you there is about 5 to 10 ml of fluid, okay, clear fluid, which is present within this pleural cavity, which lubricates the surfaces, so that to avoid friction and allow for smooth movements. So, sometimes there is excessive accumulation of the fluid, and that we call it as the pleural effusion. So, this is mainly because of the inflammation of the pleura, okay, so which we call it as pleuritis. So, inflammation of pleura can lead to this condition, that is pleuritis can lead to this condition. So, because of the pleural effusion, so when there is excess of fluid, what will happen? The lung cannot expand, correct? So, there is decreased expansion of the lung on the affected side, and because of which, like when we percuss, there will be a dull note in that area, okay, at the site of effusion. So, this is how, so the lung will not be able to expand. So, when there is collection of the fluid in the pleural cavity, we call it as the hydrothorax. When there is blood, we call hemothorax. When there is air, we call pneumothorax. And when there is pus, we call it as pyothorax or empyema. Okay, empyema. So, these are the different terminologies depending upon the content, okay, what is filled within the pleural cavity. Right. So, this is how we see in the X-ray, where here you can see there is a small collection here. So, of pleural, this is pleural effusion. So, thoracocentesis or pleural tap, okay, this is performed basically to remove the excess of fluid. So, by this process, thoracocentesis or otherwise called as pleural tap, we remove the excess of fluid, okay. It can be for a diagnostic purpose also, as a therapeutic also, okay. So, sometimes small amount of fluid is taken and it is sent for examination, pathological examination, to see what it is due to the nature of the collected fluid. And if there is large amount where it is causing the collapse of the lung, okay, and it is not allowing for the lung to expansion and breathing difficulty, then we keep a drain, okay, ICD drain we put, so that it is drained, okay, whatever the collection is drained and the lung can expand and the breathing improve. So this when we perform, okay, when the needle, the patient is in a sitting position and the patient will be bending forward, leaning forward, and the needle is inserted in the, this is very important, how we insert the needle. So the needle is inserted into the lower part of the intercostal space along the upper border of the rib below, okay. Why do we go along the upper border and why not the lower border? Because at the upper border there are no intercostal nerves and vessels, but whereas on the lower border, along the lower border, the posterior intercostal nerves and vessels will be running, okay. So that is thing. So along the mid axillary line, okay. So usually we do it in the 6th intercostal space along the mid axillary line, the needle is inserted. So while we insert the needle, what are the structures it pierces? It passes through the skin, then there is the superficial fascia, then we have the, okay, skin, superficial fascia, that is in the mid axillary line as we go inside. The first thing, skin, superficial fascia, then the serratus anterior muscle, then the intercostal muscles, endothoracic fascia, then the parietal pleura, and then we reach the pleural cavity. Okay, so suddenly as you pass the needle, once you reach the cavity, you get the feel of giving away. Okay, so that is how we will know we have entered the pleural cavity. Okay, as well as there will be, when we remove the plunger, we can see the, or we withdraw the plunger, we can see the fluid filling the syringe. Right. So that is about the pleural effusion. So next we will study the bronchopulmonary segments. Now what do we mean by bronchopulmonary segments? Now bronchopulmonary segments are well defined, okay, well defined wedge-shaped sectors of the lung. They are the functional units of the lung. So we say bronchopulmonary. So it is aerated by a tertiary bronchus. So each of these bronchopulmonary segments are aerated by the tertiary bronchus, okay, or the segmental bronchus. So when we see the features or the characteristic features of the pulmonary bronchopulmonary segment, one thing is it is the subdivision of the lobe, okay, it is a subdivision of the lobe of lung. Okay, so each lobe of the lung is further subdivided into bronchopulmonary segments. Then it is pyramidal. So if you see here, it is pyramidal in shape and the apex of the pyramid is towards the hilum. Apex is directed towards the hilum. And third thing, it is surrounded by connective tissue. Then if you see, it is aerated by, okay, it is aerated by the tertiary bronchus. And if you see, each of these segments will have its own artery, okay, that is the segmental branch of pulmonary artery. And it will have its own lymphatic drainage as well as the autonomic nerve supply. Okay, so that is why it is, you can in malignancy and all, if a particular segment is affected, we can just remove that segment without removing the entire lobe of the lung or the entire lung. Okay, so because it has its own supply of nerve supply as well as the pulmonary artery. And if we see, the pulmonary veins are intersegmental. Okay, pulmonary veins lie between the, so pulmonary vein is intersegmental, whereas the pulmonary artery is segmental. And surgically it is resectable. So it can be entirely removed surgically, that is, each segment can be removed separately without affecting the other parts of the lung. So when we see, okay, the division, because it is bronchopulmonary segment, so it is the pulmonary tissue aerated by the tertiary bronchus. So when we see the division of the trachea into the primary bronchus, secondary and tertiary, we can see how many tertiary bronchi are formed and accordingly that many number of bronchopulmonary segments are there. Now this is the trachea. So trachea is dividing into the principal, the right and the left bronchus, that is the primary bronchus, and this is divided into the secondary bronchus. These are secondary bronchus. Okay. So here now that secondary bronchus is also called as lobar bronchus. So depending upon how many lobes. So if the right side, generally there are 3 lobes. So we will see 3 lobar bronchus, whereas on the left side there are 2 lobes and we see 2 lobar bronchus. Now this will divide into further tertiary bronchus. Okay. So each of the lobar bronchus further will divide into tertiary. So now if you see here on the right side, okay, so right side, so this is 1, 2 and 3 here, okay, and here we have 4 and 5 and 6, 7, 10, 9 and 8, okay. So it goes 6, 7, 8, 9 and 10. So these are the 10, okay. So 10 bronchus on each side. So the right side we will have 10 bronchopulmonary segments, and similarly on the left side also we will have 10 bronchopulmonary segments. Then we have the 6th one, 7th, 10th, 8th and 9th. So like that 10 segments are there on side. Okay, so what are the names of these segments? The bronchopulmonary segments. Each lung will have 10 bronchopulmonary segments. So first we will see the right lung and what are the bronchopulmonary segments here. So on the right lung, the superior lobe, this is the superior lobe, we will have 3, that is the apical, the posterior and the anterior. Okay, the middle will have 2, the lateral and the medial, and the inferior will have, here if you see, will have superior here, this is the superior or apical, we can say superior, and then we have here the anterior basal, then the lateral basal and posterior basal. The medial basal we will be seeing on the medial aspect, okay. So medial basal will come on the medial aspect of the, that is the mediastinal. So medial basal will be on the medial aspect of the right lung, that is on the mediastinal surface, okay, near the hilum we can see. So these are the 10 bronchopulmonary segments of the right lung. So similarly when we see the left lung, okay, this is the left lung. So left lung will have 2 lobes, the superior and the inferior. So in the superior we see the apical, anterior and posterior. Then we will see the superior lingual, superior lingular and inferior lingular. So 5 segments in the superior lobe. And similarly in the inferior lobe we will have the superior or apical, then anterior basal, lateral basal and posterior basal. So this will be in the inferior lobe, okay. So this is how the segments are present. So clinical aspects, now this is, so here we can see the lung abscess, this is an X-ray of the lung abscess, okay. So lung abscess are more common on the right side because aspiration, so usually the abscess are secondary to aspiration, and aspirations we see more on the right side. One thing is because the right bronchus is short and it is more straight when compared to the left principal bronchus. So the foreign body easily enters the right lung. And when it remains there and it gets infected, it could lead to abscess. So lung abscesses are seen more on the right side. It is more commonly in the apical segment or the superior segment of the inferior lobe. Okay, on the inferior lobe we will see, because that becomes the most dependent part, and so the collection is more in that. Okay, the pus collection will be more in that apical part. So that is the thing. So abscesses we will see more in the superior or apical lobe. Apical segment, okay, of the inferior lobe. More on right side. So lung abscess is more on the right side, right lung. So tuberculosis of the lung, okay, it is mainly seen first in the apical bronchopulmonary segment of the superior lobe of both the sides. So why do we see there more commonly? Because that portion, the apical lobe, apical bronchopulmonary segment, is aerated less and there is less oxygenation. Okay, so when we inhale, we do not use our lung to our full capacity, right? And because of which the oxygenation, especially to the apical lobe, apical bronchopulmonary segment, is less. So tuberculous bacilli will thrive in this kind of conditions where there is less oxygenation, because it is an anaerobic bacilli, right? So we see more first. Okay, when the tuberculosis starts, it starts in the apical bronchopulmonary segment of both the superior lobes of both the lungs. So this is in the apical segment of superior lobe. Next is the bronchogenic carcinoma. So the bronchogenic carcinoma, so when we see in the lungs, we see it first in the anterior bronchopulmonary segments. Now why do we see it in the anterior bronchopulmonary segments? Because these segments are closer to the hilum of the lung. And when they are closer, why should it be seen there? Why should it be seen? Because at the hilum there are a lot of lymph nodes and lymphatics are present there. Okay, and bronchogenic carcinoma spreads to this, basically the lymphatics. So we will see it closer to the, that is to the hilum. Next, here you can see here, so they are closer here, there are a lot of lymph nodes there. So that is why the cancers are more common near the anterior lobes. Then other thing which you have to remember is localized conditions, okay, localized disease conditions like tuberculosis or bronchiectasis or even a benign neoplasm is always restricted to one segment of the lung, okay, one bronchopulmonary segment of the lung, so that we can resect that bronchopulmonary segment completely and the diseased part can be removed without affecting the other bronchopulmonary segments or the lobe of the lung. So that is why we call this bronchopulmonary segments as independent functional units of the lung. Now let's solve some of the MCQs. At the mark point, which structure is most likely present? So what is present there? The pleural reflection. Pleural reflection is present here. This is actually the costodiaphragmatic recess of the pleura here. So we see the pleural reflection there. Fluid accumulation in this recess is best detected in which position? So since it is the dependent part, right? So dependent part, when we stand, it becomes the most dependent part. So we can see it more in the erect. Which segment is most commonly affected in aspiration in a supine patient? So in aspiration, it is the superior segment of the lower lobe. I told you superior, or because that becomes the most dependent part, and in aspiration it directly goes to that superior segment of lower lobe. Which statement is correct regarding bronchopulmonary segments? Okay, so each segment has its own vein. Vein runs intersegmentally, arteries are intersegmental, bronchi are intersegmental. So we know that artery and bronchus both are segmental. So each segment has its own artery and it is aerated by the tertiary bronchus. So C and D are not right there. Veins run intersegmentally. Yes, pulmonary veins are between the segments. So that is the right answer. The label structure is homologous to which of the following? Here, okay. So this is basically the left lung, and this projection is the lingula. Okay, and lingula is homologous to the right middle lobe. So coming to this last question now, how many bronchopulmonary segments are typically present? So usually we say 10 and 10 on each side, but when the choice is given as 10 and left 8 to 10, we can take that as the right choice. So why do we take that is, on the left side, sometimes the apical and the posterior segments in the superior lobe, they will form together apico-posterior segment. Okay, so on the left side we will see that is the apical and the posterior segment together forming apico-posterior segment. And in the inferior lobe, the anterior basal and the medial basal together will form the antero-medial bronchopulmonary segments. So in those cases, instead of 10, there will be 8. So that is why we take on the left side 8 to 10. So with this, we wrap up today's session on pleura and bronchopulmonary segments. So stay consistent with this series as they bring you one step closer to your NEET PG dreams. So stay consistent, stay focused, trust in your preparation. I will see you in the next session.